Thank you, Petra. Thank you, Neha, and everyone else for making it to this learning initiative. We wanted to start this initiative, which is headed by Neha, to bring speakers and best practices from around the globe to help all of us to improve in whatever we are doing with respect to elder care. So the idea is to have different sessions from different facets of care so that we all learn from each other as well as from the best in the industry. So Neha, over to you, and thank you for taking this initiative, and thank you for bringing Petra. And Petra, we look forward to learning from you. Thank you.
Quickly take a minute to, briefly introduce Ms. Petra. Thank you, Mr. Narahari. We are delighted to have Ms. Petra Tegman with us today. She is the Palliative Care Development Manager at Bitnia Stiftelsen and has prior experience of owning and operating a private dementia facility out of Sweden. Her expertise is in palliative care and dementia care arena, and she has co-authored Sweden's first and only book in palliative care. That makes her the best person to give us an overview of elder care in Sweden. And would like to thank Ms. Neha Sinha, CEO and co-founder Epoch Elder Care, for organizing this learning session for us, and would request her to moderate this session. Ms. Sinha, over to you.
Thank you. Thank you, Bani. Thank you, Adarsh. And hi, everyone. So I think I've known Petra for a couple of years now, and she has a very, very long list of credentials, but I'll give my personal experience of knowing her for the last couple of years. And before that, Petra, I think we've given you background about Asli. Essentially, we are a bunch of very, very passionate and enterprising team members from the industry, who's each person trying to do their bit. India is a very, very diverse country with diverse requirements. Elder care is not really that linear as it is in most developed nations. So it's at a, like how I say, it's at a crossroads of trying to figure out what this nation needs. So this group over here is a very dynamic, all my colleagues in terms of, trying to do their bit and also learn. And that's the idea of why we reached out to you as, one of the first sessions. For everyone here, so I've known Petra for the last couple of years, I think 6-7 years, and I first met her when I went to Sweden to do my training in Stockholm, and I spent a couple of months. And I went through an international, an organization called Swedish Care International, who actually introduced me to Petra because I'd asked them to, help me see a couple of homes in Sweden. So I'd seen about 9-10 homes. And one of the last homes that I saw was actually Lovisa Garden, which was that time owned and operated by Petra herself. And Petra is a very senior nurse. The interesting part was, by the time I'd seen quite a few homes in Sweden, of course, very well run and organized, like you expect. But the thing about Lovisa Garden was, for the first time, I saw a home which actually felt like a home. So it was a dementia care home and palliative care home with all residents across stages. I went there, and Petra was there with I remember 2 of her dogs, who were just playing around, and the passion and the interest with which she explained to me about every elder in that house and the care that they give. I had that notion that in the Western world or in the developed world, it's very professional. There's a certain amount of only personal care that you can really do, but that kind of set my benchmark. I don't think Petra have told this to you before, but that set the benchmark, at least for me in Epoch, that you can be as professional, you can be as big, but you can also be home-like and personal. And thank you for giving me that benchmark till today. Petra is very well respected in her field in Sweden, and she's also worked very closely with Her Majesty Queen Silvia of Sweden, who she was very kind enough to introduce to me as well. And Queen Silvia is also very involved in dementia care in Sweden because she has had personal interest. Her mom had dementia. She runs a foundation from where I have also been trained at the university that is associated with that foundation. And why I thought this would be an interesting session for all of us would be, of course, to share and understand about how elder care is thought about in Sweden, because personally I felt, and I've had the privilege of knowing quite a few countries and how they operate by now. Personally, I've always felt Sweden is a very idealistic society. Petra may not agree, but it is. And what better than to benchmark our standards to the highest order? So with that, I would like to hand over to Petra, and thank you very much for taking out the time. I know how busy you are. Over to you.
Oh, thank you very much. Thank you, Bonnie and Neha, for your introduction, and thank you all for inviting me. It's an honor and a pleasure, and I will just give a short presentation about dementia palliative care. I can see that and I know there's a lot of expertise in this room at the moment, but I will talk a bit about dementia care and palliative care, the way I look at it from my experience, and also tell you a bit about the organization and how elderly care is run in Sweden. And just feel free to interrupt anytime. Neha, you will moderate, and just stop me anytime if there are any questions or anything else. Just feel free to interrupt and ask. So my main question all the time when I work in elderly care is the question, for whose sake? For whose sake are we doing what we're doing? For whose sake are we going to work? For whose sake are we deciding what kind of medicine to give, what kind of activities to do, everything we do? If we always can answer the question that what we are doing is for the patient's better, then yes, we should do it. Otherwise, no. Sometimes we end up in doing things for another person's sake, that we provide medicine because there might be that a patient with dementia is very, very stressed, very, very agitated, full of anxiety, and might not be given the right kind of communication or treatment, and might be disturbing for the other guests in the nursing home, perhaps. So just because we want to calm down this patient, we give him medicine so the other ones can be more at ease. But to me, that is not the right way to do it. We need to focus on what does this patient need and what can we do for him and her to ease all his suffering and ease all his pain that is causing him this distress and this agitation. And also activities. Activities has for a very long time been the big cause of discussion here in Sweden, that potentially perhaps you have been a very active person all your life. Then you get an Alzheimer's disease and you get a bit more anxiety, a bit worried. We all know the change of environment is very crucial. It gives me more confusion. So maybe we have just had our last walk. Maybe just leaving the nursing home gives me more anxiety and a bit of worries. So maybe I shouldn't take those walks any longer. Maybe I should just sit on the balcony and get some fresh air and walk around in the garden or something like that, but not to go for a long walk, which is very popular in Sweden. And sometimes we end up in discussions with the family members that, oh, my father has always been out for a walk daily. He has to go for a walk daily. So you have to take the walk today. But for whose sake are we taking the walk then? Is it for the family members or is it for the patient? As long as we do it for the patient, if the patient is still enjoying the walk and benefits from it, of course we should do the walk. But if not, we have to figure out, is this for the patient's best? Or should we just stay on the balcony? So always ask yourself, for whose sake are we doing what we're doing? To me, knowledge has always been the key to understanding and success. The more we know about dementia, what happens, first of all, in the brain, what kind of symptoms that could happen, what kind of symptoms that the patient could develop. And the more we know about the patient himself, what kind of needs, what kind of abilities, what the patient likes, anything about the patient himself, the more we know about him, the better kind of care and treatment we can give, the better way we can interact, and the better we can communicate and understand the patient, the better he will feel, the better kind of quality of life he will get. So the more we know and understand of dementia and of the patient himself, the better we can succeed with what we're trying to offer, and the easier we will achieve a better quality of life for the patient. So knowledge is crucial. Sometimes I get the misconception of dementia just affecting the memory, and that's it. But we always have to understand that it affects more cognitive functions, and we need a lot of support, different kinds of support through the different stages of our Alzheimer's disease. And the more we understand of that, the better ability that we have to succeed with the treatment we're giving. And making the patient feel confident, which this is all about, especially either in their own home through home care or when they move into the nursing home. The better we can comfort them and make them secured in the new environment they are in, the better quality of life they will get. So as a repetition, you all know this, dementia, collective name and a diagnosis for a range of symptoms caused by brain damage, disease, or trauma. As I mentioned, sometimes we get the misconception that we always only talk about memory, but we have to know that it involves continuous permanent loss of functions and the emergence of new symptoms. Permanent loss, one of the things that the patient will eventually lose if he or she lives as long, is the ability to walk. The brain will suffer enough damage for the person not being able to stand up and walk properly. This is like one of the things that can happen eventually. And this is another topic that always comes to discussion with the family members, that if you lose your ability to stand up and walk, we have to start walking training again. But if the damage, the brain damage is that big, so that it has affected the ability to walk, we will not be able to train and get it back again. It's a permanent loss of function. But for us being caregivers, we have to always be very considerate about, well, today he might not be able to walk from the bed to the bathroom, but potentially from the bathroom out to the kitchen, and then sit in a wheelchair. But tomorrow he might be able to walk from the bed, his bed to his bathroom to the kitchen. And tomorrow, the day after tomorrow, we might need a wheelchair. So we have to be very considerate about when this happens, when this stage happens to the patient, we have to be very considerate about, can we walk today? Can we try to walk today? Because physical activity, as we all know, is good, of course, but if we have lost the ability to walk permanently, we will not get it back. It also, when it comes to eating with knife and fork, for example, we will lose that ability. We might need to start eating with a spoon. Next stage might be that we have to spoon feed the patient himself. We have all different kind of stages that we have to know about to be able to give the right kind of care for the patient. What is also crucial to understand that this is not belong to the normal aging. This is something I talk a lot with the family members about also. This is a disease, and this is also something we need to train all our assistant nurses and staff with, that this is not a normal aging. This is a disease that can affect any one of us. And in fact, at the moment, it is one in a lot of states in America is considered the #1 highest cause of death at the moment. It is Alzheimer's, and especially among women. And the statistics say that 1 out of 3 will get Alzheimer's or another cognitive disease. And the disease itself, the diagnosis, means that I will need your help. I will need your assistance and your help. Not as much in the beginning, but as long as the disease progresses, I will need your help and assistance. And what we also need to know is that this is not a single person's job. Not one person can provide all the care that a person living with dementia needs, all the kind of supporting care. We always have to focus on the family members also and let them know that this is, you need help. This is not something you can do year in and year out by yourself. You need to get some assistance and get some help. So always remember that and let the family know, because sometimes I meet family members that feel a bit disappointed by themselves because they're not able to give full care for their husband or their wife or mother or father, but it is a full-time 24/7 job. So let them know that you're here to help them. Palliative care is getting very well developed in Sweden, better and better year by year. We get care programs that tell us what to do. We always also have recently started this process through our care system, where we can find the palliative care patient and what kind of treatment or care we should offer him or her. Palliative care is very often misunderstood for being end-of-life care, something that we provide only in the last stages of life. But we are trying to look at it as at a broader perspective. When cure is no longer possible and the disease will lead you to death. The only thing is that if you potentially get a cancer diagnosis that is untreatable, you can have many years when we can try to slow down the progress of the cancer. We might not be able to treat your cancer, but we can slow down the process and do a lot of things that can help you get a higher quality of life. It's the same with dementia. Even though you get an Alzheimer's disease, which is a deadly disease that we cannot cure, and the disease will lead to your death, we can always do a lot of things for the patient in the early stages to make him or her have a really good life despite the disease, despite Alzheimer's. But we cannot treat Alzheimer's disease at the moment. We all know the research is getting closer and closer, but at the moment we cannot. When it comes to palliative care, we always have to keep a holistic view of the patient, meaning that we cannot separate body and soul. We have to see them as one. We are often, through medicine, very good at treating physical pain. We can prescribe Panadols or morphine even in the palliative care, but we are not as good as finding other kind of pains, like psychological anxieties and worries, also social pain. What will happen to my family members? What will happen to my kids? And existential pain. What will happen when I die? Is there another life after this? What will happen to me? What will happen to everyone else? All those kinds of pains that the patient can have and can suffer from. We have to find that too, not just a physical pain, but also the other kind of pain that could need, other than just a pill. Maybe the patient needs to sit down and talk for a while, just communicate, being comforted, having someone around to make you feel confident and secure, and not just saved by the pill. So always have a holistic view and holistic approach to the patient. Sometimes I also think that, especially when it comes to dementia, we can find patients that are very worried, very anxiety, and we try to give them a pill for their anxiety or for being worried. But it might be that the patient is suffering from kind of physical pain, maybe back pain, something in their tooth, or something like that, but they cannot express it by themselves due to the dementia disease. So we have to figure out through pain assessment or different kind of symptom assessments, what kind of suffering is the patient going through. And this is also, we definitely have to be small detectives to try to find out what the patient is suffering from and what is hurting them. So always use the holistic and the broader perspective, because palliative care is all about easing suffering. How can we ease your suffering? We cannot treat your disease, which is what we're all treated to as doctors and nurses. We're all trained to. We're trained to cure and to make you live longer. But what if that is out of the question? We cannot do that for this patient. Well, then we have to turn and think about the palliative care perspective, ease all the suffering we can, and make sure that the patient is getting the best kind of quality of life despite the disease. So why is palliative care important and relevant in dementia? Well, I already said it, because dementia leads to death. In Sweden, cancer has always been the number one diagnosed what is connected and related to palliative care. But in Sweden at the moment, we say that we can treat or cure 6 to 7 out of 10 that gets a cancer diagnosis. And as I mentioned previously, we cannot treat anyone that gets cognitive disease or a dementia disease, which is why a dementia disease is, through definition, a palliative diagnosis already when you get the diagnosis. So if you get an Alzheimer's disease, think about the palliative care perspective. And sometimes this can even mean that we don't give some kind of treatment. We don't do some kind of, perhaps if we have an older lady that is gets severe dementia and you realize, well, here's a breast cancer. Are we going to treat that? Are we going to operate, chemotherapy, radiation, causing a lot of different kind of suffering because of the treatment when the patient has a deadly disease already, or that will kill her, unfortunately, the Alzheimer's disease? Or should we try and just don't do anything about the breast cancer, but try to ease all the suffering that can come with it? This is not an easy question. These are ethical discussions that need to be brought up all the time, because it all ends up to what could be the best kind of quality of life. But always remember that palliative care could in the early stages be about giving treatment to stop the disease from spreading any further, if possible. But it can also mean that you don't give some kind of treatments because it potentially could cause the patient more suffering than benefiting. So it's an ethical discussion that is always needed to bring up. In Sweden, we are working a lot on these issues and always trying to make the patient and the family look at all the kind of treatments as an offer that we can give you. And we always include them in all the discussions about the options and what we have. When it comes to people living with dementia, of course, this is another topic and it's more and more difficult, but we always have to include the family members.
Petra, can I interrupt for a minute?
Sure, of course.
You're comfortable me asking you questions in between, right? Would you like us to park and for the rest of the group, would you like questions at the end, or do you want them to put them in the chat box? How would you like to structure it?
Doesn't matter to me.
You're comfortable this way, right? So just so that you know it's caught in your flow. So you mentioned two things, and I remember us discussing this also, that you mentioned that the system is kind of gearing up a lot towards palliative care, and in Sweden we are also looking at incorporating this in dementia care a lot. So when you say the system, do you because we would like to understand also a little bit about how elder care works in Sweden in general. So is it the private sector or is it the government? I know elder care is the responsibility of municipalities in Sweden. So could you just give us that context a little bit?
Sure, I can move further and go back if we have more. So the Swedish elderly care system is based on it's a welfare system based on tax funds. And out of Sweden's today 10 million inhabitants, more than 20% have passed the standard retirement age, which is 65 years of age. And 65 years of age is also when you move into elderly care in Sweden. If you are younger than 65, we have different kind of rules and laws. But if you are above 65, we can provide you through our welfare system with elderly care. Life expectancy in Sweden is among the highest in the world at the moment, 81 for men and 84 for women, and 5% out of our inhabitants today is above 80. So we have quite a big population of elderly, which I know you also do have in India and getting older. So the region is responsible for healthcare, and one of the aims of elder care in Sweden is, hang on, I'm just going to see if I can move this one so I can see. One of the aims of the elderly care is to help elderly people and those with disability live independent lives. And this includes living in their own home as long as possible. And when that is not possible any longer, you are always given the option to move into a nursing home, which is tax paid and provided by the government. Elderly people who continue to live at home can obtain various kinds of support to make life easier. For example, almost all municipalities in Sweden offer like a ready-cooked meal that can be delivered to your home, and assistance in the home. And in 2020, home help staff assisted around 236,000 people above the age of 65 in Sweden. So there's quite a large number that get home care in Sweden. And well, when an elderly person is no longer able to cope with the demands of everyday life, he or she can apply, as I mentioned, for assistance from the municipality and move into a nursing home. And elderly people with disabilities can receive assistance in their home or in a nursing home around the clock. We can also have this if you have a disability from earlier, before you were 65, you are also able to have assistant living in your home 24/7, or you can move into a nursing home if you want to. So it depends a bit. And also another option, actually, if you live in Sweden and are above 65 and get a cancer diagnosis, you can also get hospital care in your home through assistance coming to your home, and that is the palliative care perspective. So, and the system in Sweden, as I mentioned, is tax funded. Each municipality decides its own rates for elderly care, and the only thing you pay for is some of the care and the food that you are provided. But there are maximum taxes, and we cannot charge more than you can pay. You're always allowed to have some kind of money or some amount of money left that the government cannot take. So it's only a small amount that we can ask for you to pay for your elderly care. And some of the municipalities have privatized the palliative or the elderly care. So we also have non-profit organizations, we have private organizations, and we have elderly care that is run strictly by the municipalities. So, and when you need assistance, when you need care, either in your home or in a nursing home, you contact your municipality where you live, and you will be provided with a case manager that will make sure to guide you in the right direction and make sure you get the kind of quality of care and the kind of care that you ask for and also that you need. So a case manager is the person that has the ability to say yes or no to all your questions and through what you need. I don't know if that was a good enough answer for you, Neha.
Yes, thank you.
Correctly.
Yeah.
Good. So the elderly care in general is based on laws and regulation. You cannot just be a person in Sweden and say, hi, I want to start a nursing home. You have to apply for the government to get a permit to open up a nursing home. And it's all based on different kind of laws and regulations that you have to follow as a caregiver. There are several rules that you have to follow related to how many staff you have, what kind of staff you have, for example, how big the units are. And when it comes to dementia, we cannot have more than 10 people with dementia living in one ward. That's the maximum. We always have to have staff 24/7 in the ward. They can never be left alone. And the lowest level of educated staff is assistant nurses, and they have all been trained and educated for 2 years to get an assisted nurses diploma. This is now on June 1st, is this becoming regulated title as a nurse or a doctor or a physiotherapist. By June 1st, we will have a regulated working professional title called assistant nurses. It has previously just been training programs, but now it will be more regulated, and they have to on a higher level prove their competence, and the nursing schools has to prove what kind of education they're giving their staff.
So Petra, this is when you say nursing homes, you also mean assisted living homes, or do you strictly mean
Yeah.
nursing homes?
No, it's the same in Sweden.
It's the same, right? So
Yeah.
the terminology for assisted living homes, so there's independent living, which is done mostly at home in Sweden,
Yep.
from what I understand. And
Yeah.
then if anyone moves to a residential care, that's the nursing home category. And there
Yeah.
are these are the law, these are the regulations you're saying apply for.
Yeah. Yeah. And then in the nursing homes, we have people living with somatic diseases or wards with people living with dementia. So if you are just, which is the unfortunate thing in Sweden, what we are really lacking is supportive care homes for elderly that are doing quite well. It does not live with a dementia disease or doesn't have a lot of somatic problems, but are just feeling lonely in their home. That's the part where we are lacking in Sweden, because if you're like only that kind of patient who doesn't need a lot of support, you are supposed to look after yourself, which is very, very unfortunate in Sweden. And that's where we get a lot of, especially internal critic in Sweden. There's a lot of negative discussions about it. They should be able to get more like supportive homes. Definitely.
Right. Please go ahead.
Yeah. Also, in all the nursing homes, we need to have nurses, obviously, especially in daytimes, depending on how big the unit is. We also have, if there are larger nursing homes, they have 24/7 nurses. Otherwise, nurses are on calls during the night. Doctors, they are not there 24/7 and not in every day, depending on also how big the nursing home is, but usually they are on site about once a week. And also the same with physiotherapists. And physiotherapists are the ones that are helping with all and prescribing all kind of aids and tools that are required in a nursing home. For example, the normal wheelchair with a low back. When people are getting more with, especially with dementia, getting more and more severe dementia, we always prescribe the ones with a higher back so the patient can lean back and decline and sit in a wheelchair for longer, but also to sleep because they are fully reclinable. In all the nursing homes, we also have these kind of nursing beds that you can lower and higher just to be able to make the work environment for especially for the assistant nurses better and easier. Walking aids, we have several different ones. This one I think is very pretty with like a golden shine to it, but different ones we have a lot. And this one, the share at the bottom to the right is for showers, a shower tool, so a share on wheel. Also kind of aids we have, this is a mat that you put next to the bed. You might have seen them also, that has the alarm system to it. So when the patient, to prevent from falling, getting up. GPS watches, camera surveillance. Camera surveillance is not allowed in Sweden if you are not able to say that, yes, you can keep a camera on me. So there's a lot of ethical discussions going on all the time when it comes to people living with dementia. Should we or should we not have camera surveillance in the rooms? And in the cases we can, the camera cannot be on all the time. You can put it on for just a few seconds to make sure that the patient is still in bed without going into the room at night to check on the patient. But besides that, we are not allowed to have camera surveillance. The bottom picture, you can see, I think I have better pictures of it. Yeah, pre-packed medicine, dose-packed medicine, which comes in rolls for a fortnight. So for 14 days, pre-packed medicine, which is a very good tool, especially in home care. If the patient has their own medicine in their home, these are all pre-packed to make it easier to keep track on, oh, did I take my medicine this morning or did I not take my medicine this morning? So this is a very convenient system that we have in all Sweden. I don't know if there was any question about that, Neha.
No, I think I'll let you complete.
Yeah, okay. Just a short thing about person-centered care, which is something that we talk a lot about in Sweden also. We're trying to move further away from task-oriented care, where we always look into this is the time when you wake up, this is the time you have breakfast, this is when you shower, this is when you go for a walk. Instead, we're trying to turn it around and look at it in a person-centered perspective. What do you want and when do you want it? We go through trying to see each individual's unique needs and abilities, and also base it on the person's wishes and needs. For example, I am a morning person. I always get up early in the morning. I like to have an early breakfast. So if I would be in a nursing home that only served breakfast at between 8 and 9, I would probably be very hungry until 8 o'clock. So if that happens in Sweden, we try to give an early morning snack or an early breakfast or something like that. Also, what happens a lot in a nursing home, I'm sure you've heard about it also, is that somebody comes up claiming that they haven't had breakfast. I didn't get breakfast today. And being task oriented is to say, yes, you did. You already had breakfast. You have to wait for lunch. But if we use a person-centered perspective, we would say, oh, you didn't. Oh, my mistake. Sorry for that. Come and have another breakfast. And also in Sweden, we have been very focused on setting 1 day a week for showers. For example, you move into a nursing home and you get Tuesdays as your shower day. But we try to be as flexible as possible because we're 44 person in this room. I am sure we have 44 different ways of looking at a shower. We do it in the morning, we do it in the evening, we do it both in the morning and the evening. I wash my hair every day or every third day, long showers, short showers, cold, warm, different perspectives. What kind of way, in what way would you like your shower? What is the person-centered approach to help you get cleaned on a daily basis? So try to figure out what the person needs, and also to think about the person comes first and then the disease. Try to, despite the perhaps Alzheimer's disease, don't see the person as a demented person. See the person comes first, and the person has a dementia disease and needs your help and your assistance, but focus on the person first and not the disease. And always, as I mentioned in the beginning, also use the phrase, for whose sake are we doing it? For whose sake are we moving into person-centered care and looking into everyone's best and not being just only task-oriented. As I mentioned, the holistic perspective, the total pain perspective, think about physical, psychological, social, and existential needs of the patient always. And when it comes to pain, I have the 3 Ps when I talk about elderly care, and especially in dementia. Always try to think about pain assessment. How can we assess and figure out what kind of pain the patient is suffering from, and how can we provide the right kind of pain relief? Is it a pill? Is it massage? Is it company, comforting? What kind of relief do we need to give the patient? Or is it aids, for example, like a better mattress in the bed, something comfier to sit on, or whatever the patient needs to get pain relief for all kind of pain he or she could experience. And also pain prevention, very, very, very crucial. For example, when a patient is being more and more bedbound, the risk of bed sores is of course increasing. So we have to think about pain prevention to prevent the patient from getting bed sores, which can be really, really painful. And if the patient gets a bed sore, remember that it might not always be able to heal it and to cure the wound, but we can always relieve the pain from the wound. And you have to talk to the doctors and see how that can be done and what kind of medicine the patient needs for it. I always talk last slide about brain, heart, and hands. As I said in the beginning, you need knowledge. You need your brain and your knowledge in your brain. You need your empathy in your heart, and you need your hands to be able to provide good care for the patient. So use your brain, your empathy, and your hands to provide the best kind of quality of care for your patients. Thanks.
Thank you, Petra. That was, I always really get inspired when I listen to you. And it's just so nice to, have you here. We have a couple of questions on the chat box, and I would request anyone else. I have a couple of questions from my side as well. One of the questions we have from Sri Kumar is, I'll just read it out for you, Petra. In a country like India, less than 10% of persons with mental health get diagnosed, and a much less percentage of them get treated. So mental health, dementia, any of these conditions. So how is the scenario in a developed country like Sweden? Because in India, it's mostly, a reactive scenario. You're in trouble. You notice some changes, and that's when you kind of say that, okay, I need help. So how does it work in Sweden?
The mental health issue is still a struggle. We are trying to provide better care through all ages. This is still, I would say, in some regions, definitely some parts of Sweden, it's a lack of system working. We still lack of good competence and structural system for finding and identifying mental health issues. So it's a struggle, and we have recently found out that among younger people, the suffering is quite big, and there's a lot of people with mental issues, but this is an ongoing topic all the time, and there is election coming up this fall, and this is a topic. When it comes to dementia, we're getting better and better in providing better diagnosis, early assessment and early diagnosis, and we're getting more and more tools and aids. For example, there's one called Jera Solutions that can provide home testing through an iPad or something like that, so you can try your cognitive functions. And it also comes down to an assessment with some kind of diagnosis. I'm not sure about exactly how the system works. I've seen it a couple of times. It's very inspiring. It takes like the MOCA, the mini-mental test, and some of these assessments all in together, and provides you with an easy test that is easy to understand for somebody with a cognitive decline. So it's a good way of assessing. And we talk a lot about the need of early assessment to be able to find these people and to give them the kind of symptom relief medicine that we have today, and get them into our healthcare system and making sure that they get the right kind of care that they need. But it is difficult, and it is to the healthcare problem, the mental health problems, and the cognitive decline in patients are like seen upon as two different things in Sweden. So.
And does dementia get categorized under mental health, strictly under the laws?
No, under elderly care.
Under elderly.
So, yeah, geriatrics, yes.
Understood. Srikumar, why don't you ask I think you have a bunch of questions. Maybe it would be great if we can all interact directly. I'll just play facilitator. If you could raise your hands, and I think that's done the best. Shri? Another question, I think, while he's here is one thing we wanted to also understand. Some centralized best practices and information on palliative care in Sweden. And is there a place where people can find important information that is verified and credible? And is this organization a private or a public one? So is there one place where you want information on palliative care in Sweden?
Yes, there is one organization that is in some ways governmental funded, that has the responsibility in collecting information about palliative care and palliative care approaches. And there is a collaboration also with professors and doctors and trained nurses around Sweden, which we are about, I think we're 25 that are gathered and try to collect and work out care programs with all the kind of directions and guidelines that are needed when it comes to palliative care. So yes, there are websites and information sites there where you can find information, yes.
Sure. Dr. Charu, would you like to question?
Thanks, Neha. Thank you so much. Am I audible?
Yeah, you are.
Yeah, thank you, Neha. Thank you so much, Petra, for for giving such great insights about palliative care in your country. One real fundamental of palliative care is the pain control, and pain control becomes very difficult in our country in a home-based environment because we have to prescribe a lot of medicines such as Dexmed or narcotics, midazolam, which have a lot of barriers, and the government institutions technically do not allow us to prescribe certain medicines, most of them technically in a home-based care. It requires a lot of documentation and becomes very, very difficult for the patients to achieve it. How's the situation in Sweden in the palliative care experts giving the free hand to prescribe such medicines for the right patients in a home-based care?
Good question. Sorry to hear about your situation. I can understand the frustration if you can realize the patient is in pain. In Sweden, we are quite generous, I would say. The system is regulated, but the patient comes first. If the patient is in need of narcotics and stronger painkillers, he or she will get it. And sometimes, as I mentioned, it could be through palliative care organization coming to your home. We have digital pumps that we pre-pack with medicine that can be administered subcutaneous.
PCA, PCA.
Yeah, that sends medicine in, and we go there every 24 hours to pre-pack it and make sure that it gives it the right dosage, and also adjust the dosage, especially with midazolam if needed, because patients suffering especially from both dementia or cancer and cancer are very highly sensitive. So we have to always adjust the dose, and that's a way of securing that the patient is getting the right. Of course, it happens that especially tablets in a home environment goes missing, but it is our job to make sure that the patient gets what he needs. Yeah.
Great, thank you.
Thanks.
Somebody from Atashri Home's team has asked this question. How do you deal with a patient requiring interventional care for treatable condition while the patient is not signed a physician's order for life support treatment?
Once again, if the patient is not ordered life
support, yeah, physician, so not signed a physician's order for life support treatment.
I think we have a different kind of system here in Sweden. If I understand you correctly, in Sweden you get all kind of support all the time until the doctors sign and do not resuscitate
The DNR order, yeah.
Yes. Until that, we always discuss with the patient and the family what kind of treatment the patient could benefit from. In Sweden, the patient cannot, they can ask, but they won't be given all the kind of treatment that they might ask for if the doctor doesn't believe that that you will benefit from it. I'm not sure if I understand you correctly there, but I think there's different ways in the system. We offer treatment to the patient through what the doctors seem could be the best kind of practice out of experience and knowledge for this patient. And it's up to the patient to say yes or no. But the patient himself cannot ask for different kind of treatments or cannot require treatments.
It's not about the patient wanting a different kind of treatment. I was just asking about see, there might be a treatable condition and a non-treatable condition. which might interfere with the quality of life of the patient. So, if at all, that decision has to be taken, whether the physicians have the authority to revoke that loss, maybe, or you will just, because since it is a government-funded care, would you just say, okay, since the patient is diagnosed with dementia, just don't do anything?
You're breaking up a bit, but if I understand you correctly, perhaps the patient has a dementia and gets a disease that is treatable. And so even though he has a deadly disease, if we should treat the other diagnosis.
Oh.
Yeah, we always do if it is something that would benefit for the patient. So for example, like urine infections and pneumonia, not if they're like severe pneumonias in the last stages of life, but yes, we would treat it, absolutely. And early stages of Alzheimer's, for example, if a patient get like breast cancer or something, we would treat it, absolutely, if the patient would benefit from it. It is when it comes to like the mid or later stages of dementia disease, we have to like have a broader perspective. Is this treatment, even though you get another disease that is curable, we have to think about the cure and the treatment. Would that be a bigger burden than getting higher quality of life for the patient? Then we should consider if it is worth it or not. I hope that was good enough answer to your question.
Yeah,
but
yeah. In that case, probably the patient can go into more comfort care rather than the interventional care.
We do give interventions, yes, if the patient would benefit from it. Yes, absolutely.
Am I audible now? Can I ask a question?
Yes, please.
Yeah, okay. I think there was some problem on the mic earlier. Now, this is specific since we are addressing the forum of the Association of Senior Living. Petra, I wanted to check out with you, one, how equipped are the retirement communities, our senior communities in Sweden to handle the incidence of palliative care? Are there any data points on the percentage of people who need palliative care in such communities? And is there any government regulation for these communities to have this specialization, since it's a age-related requirement as per the definition? You're saying that dementia is under the senior portfolio in Sweden.
Yes, if you are in need of palliative care in Sweden, it doesn't depend on where you're living. Despite where you're living, you're supposed to get it. You're supposed to get palliative care. And to me, palliative care doesn't, as I mentioned, always has to be about having a disease that is untreatable. It could also be about you getting closer to end of life due to high age. So pain relief, symptom relief should always be offered. And in Sweden, we actually have a register that is quite unique in Sweden. Is the palliative care register. So every time a patient dies in Sweden, we put into a register the patient's last week of life. Did he have bed sores? Did he die alone? Did he die with pain? Did he die with anxiety? We have like 10 different kind of measure points to make sure that we always develop the palliative care in Sweden. Through every unit, you can like look through your unit and see how we are doing. Are people dying here alone? Are people dying here with pain or with bed sores? Well, then we have to do something about it. How can we provide better quality of palliative care in this unit, but also in a broader perspective in this country? And this is quite unique register. I don't know of any other country in Sweden or in the world that has it, but it's a good way to always improve the palliative care. So yes, it is in the system. You should be allowed to get it, despite what age you're in, even if you're 2-year-old dying with cancer, or if you are 92-year-old dying out of high age. Palliative care is about symptom relief, and you should always get it.
Yeah, it's like tracking quality of death as much as quality of life.
Yes.
I remember I learned that term first and I was like, wow. I think we have the last couple of questions. I'm just looking at the time. Mayank, would you like to ask your question directly? So while Mayank
Yeah, sorry, Neha, I was speaking on mute. I didn't recognize that I was on mute. Thank you, Petra, for your insightful session that you have given. Two quick points which I just came across was what type of digitizations tools have been used within the institute to monitor the health of the patients which are there? Are they continuous one, or are they based on the nurses which are there into the system? Point one. And second, how is the feedback and the circle loops been closed with the family members when the patients are there?
The first one, I think, what we have, if I understand correctly, we have different kind of, not technical tools, but a lot of assessment tools that we use to keep track of the patient systems. Technical tools, I am not sure what that could be. Despite all the other things that the regular things that we use to check patients' paramedics, like saturation, blood pressures, and so on, that we use if needed, which we don't use in the last stages of life, obviously, but pain assessment structures is what we use mainly. And the last question was, once again, I could not really hear you. Can you please?
It was onto the feedbacks back to the family. How has that been taken care of?
All the time. Family, as I mentioned, family members are a super important part of the palliative care perspective. We always make sure that they are part of our team, and that we don't ask them what they think would be the best when it comes to treatment. Instead, we should, out of knowledge and experience, tell the family what we believe would be the best for their family member, and always keep them on track. We say that we want to keep the family members on the train with us all the time. So even though the situation is really sad because their family member is dying, but we should always let them know that we will do everything we can to keep them with no pain, with no anxiety, no worries, but keep them in the loop. And as I mentioned, sometimes I hear that people are saying that, oh, these family members are so difficult, but try to look at it in another perspective, that these families are having a difficult situation. Their family member is dying. So always keep them, like, and as doctors, as a nurse, what I appreciate most from you doctors is when we communicate about how the patient is doing, what kind of needs and abilities the patient still have, and talk about the requirements of the family. And I know how much it means when a doctor calls to the family and tells them that this is the situation, this is what we can see, this is what I can see out of my knowledge and experience, and this is what we will do for your mother or father or your family member. But keep them close to you and give them information, a lot of information. And I also want to say the palliative care is not about working with death. It's about working with life. Our patient is still living, and our job is to make sure they have the best quality of life until they die. But remember that they are still living until the last breath. We should always do whatever we can to ease their pain and ease their suffering.
Yeah, never lose hope.
No. Never.
So a quick follow-up to Mayank's question, actually, on the digitization part. So is there a central app kind of a thing, or a database where every elder's records are fed in, and if they're, let's say, transferred from home to hospital to a nursing home, and it's the same database which can be accessed by various care providers?
No, unfortunately, we have 26 regions in the whole country, and we have more than 250 municipalities. And the regions have different kind of chart systems, digital systems. So there are only some amount of information that can be spread between the organizations. And sometimes the region which provide the healthcare cannot even communicate with the municipality that provides the elderly care. So that if the patient moves back and forth from the nursing home to the hospital, sometimes the information is going missing, because having a digital chart system is privatized in Sweden. So we have different systems and different organizations that provide it, which is big mistake. All of us nurses and doctors believe that it's a big mistake. We should have one system so we can always find the right information about the patient. But unfortunately, that is not the case at the moment. So there is sometimes, unfortunately, information gone missing, and that is not safe for the patient, unfortunately.
Right. We have one more question from Harish. I'll just read it out on behalf of him. If Harish, you're here, you can, of course, pitch in. So he's asking about the role of placebos in managing pain or other psychotic symptoms. Are placebos used in Sweden frequently?
Or which used, which?
Placebos. I don't know if there's another term. So essentially, like, let's say you give a vitamin and you say that
Okay.
give a vitamin and, you know, sort of it acts like a placebo.
If placebos are used in Sweden?
Yeah.
No, not allowed.
Not allowed. Oh.
No, we cannot lie to our patient. If the patient needs if the patient needs medicine or kind of a treatment or something, we always have to provide it. We cannot give something else. And but once again, the patient cannot ask himself. It's up to the doctor to prescribe and decide what kind of medicine you should have. But we do not prescribe placebos. No. I don't know in what case that could be necessary in elderly care or in Sweden to provide it, but
doctors in this group would have a better response to that.
Like, when is it used and what when do you need it?
I mean, Harish, would you want to add context?
I'm so sorry. So generally, we actually see, Petra, a lot of patients with stage 4 cancers, giving a very good response to placebos. Although even here, we have legal obligations of telling the legal guardian about whether we are prescribing placebos or is it a part of our treatment plan. But we see that a lot of them suffer from anxiety issues. A lot of them suffer from chronic depression, mood stabilizers, and just to kind of alter their side effects, we start with a physical therapy, a placebo effect medicine, and also behavioral cognitive, kind of session, which works wonders. So it's never just the placebo, it's never just the medicine, but it's mainly with the counseling that an anxiety or a mood disorder patient or a depressive symptoms get better in a stage 4 cancer patient. So I personally use that, but under the documentation done by their legal guardians.
Well, if it hires the quality of life for the patient, if it is working, why not?
Exactly.
That's the purpose. Yeah, sure.
Takes away the side effects as well.
Yeah, for sure. Interesting.
Praveen, would you like to ask your question?
See, regarding placebos, typically we don't follow this procedure in dementia patients because there could be drug-drug interactions, and as such we try to reduce polypharmacy in geriatric patients. So we don't use placebos.
When it comes to polypharmacy, we have not a rule, but it's a guideline that the patient should not be prescribed more than 11 different pills. So we have like a number of 11 that the doctor always should try to keep below 11.
Yeah, Praveen.
Hi, Petra. I have a small question. It's more from the operational point of view. We know that palliative care and dementia care are people-centric. So are there any ideal ratios we recommend in terms of X number of patients should be taken care by X number of nursing staff or versus a doctor and things like that? And what is the ideal number a center should be managing for an effective result?
Good question. Actually, about 5 or 6 years ago, the government started a research to try to figure out what the ratio would be. But in the end, they decided that they could not give a number because it also depends on what is the staff supposed to do. So for example, in some nursing homes in Sweden, we have cleaning staff, we have chefs. So the assistant nurses only only, but they are focusing on the care that they're providing. But in other nursing homes, the assistant nurses are supposed to provide care. They're supposed to cook all the food, do all the cleaning, do all the laundry. So to me, it's not always about how many staff is around the patient. It's also about what they're supposed to do. What are their tasks and what are their obligations? But in Sweden, we decided that it was difficult. We had to try to figure out other ways to focus on what is good care. And how can we look at a nursing home and say that, okay, this amount of staff is enough to provide good care. But we always have the obligation also that if we have a patient that is suffering from severe BPSD, for example, severe symptoms and needs a lot of assistance, as a caregiver, I have to make sure that he or she gets the right amount of attention all the time. So if needed, I have to get extra staff in. So there's a good quality of care for the whole ward. But there is no ratio number. The only thing we have a number for is we're not supposed to have more than 10 people with dementia living in one ward. And there should always be at least one night assistant nurses at night. They can never be left alone. But I would say the normal ratio in a daytime would be for 10 residents, 2 to 3 assistant nurses, and like half a nurse. So one nurse would be in charge of 2 wards, so approximately 20 patients. So she would be through both wards, and then in each ward there would be 2 to 3 assistant nurses during the day.
And how many patients in a ward?
10.
10
maximum
patients in a ward. Okay.
Maximum 10.
Thank you.
Thank you.
Anyone else? Any other questions? I think before we, kind of wrap up, Petra, one of the things that, I wanted to understand really from a macro perspective is how would you summarize elder care in Sweden? I know it's a very philosophy-based approach that even the government has, but what's really the goal and the summary of elder care in Sweden?
Well, I would have to say that I've been lucky enough to see elderly care in many countries. I'm especially now at the moment working with a nursing home, a newly opened nursing home in Lithuania, to see what the elderly care is like there. I've been to India. Happy enough, I've been to Epoch and seen your nursing home. I also seen other parts of elderly care in India. I know you're struggling, and I know difficulties to get the right kind of elderly care system for you. But I would say in Sweden, overall, in general, we have a really good elderly care system. If you are in need of care, you will get it. Absolutely. The quality in different kind of nursing homes, of course, they vary a lot sometimes. And during the pandemic, we've been struggling a lot, and the elderly care has got a lot of negative publicity. But if we compare to other countries, Sweden is doing really, really well. We have a lot of well-trained staff. To me, as a passionate elderly care nurse, I sometimes think that what could really be the struggle in the elderly care is potentially or perhaps the lack of empathy in staff and the lack of motivation in staff. So we have to keep the staff motivated, make sure they still have their heart with them when they are giving the right kind of care to the elderly. That is my main goal and my mission all the time. But elderly care in general in Sweden is very good. I would have to say that, yes.
Yes, and I have, of course, experienced that. And like I said at the start, that Mohit has made a very interesting comment that India can't be Sweden, but our respective communities and homes can all aspire to be a little mini Sweden, or at least benchmark ourselves into what we want to achieve. So Petra, on that note, thank you so much for this lovely, lovely session. Anyone else, if there are any comments, anyone wants to reach out, I'm taking the liberty to say on behalf of Petra, she's very, very approachable, very happy to share her knowledge constantly. I've learned a lot from her. So yeah, so please do let us know. Thank you very much, Petra, for taking out the time.
Thank you for having me. Really, really nice. I just wrote to Neha that I wish I would be there in person to meet you all. I always say to Neha that I think my previous life I lived in India. I love coming to India, so I'll be back soon.
Yes, we should make that happen, and we'll organize another session when we can really, and seeing you in person is even more inspiring, and totally vouch for that.
I would love to. Have a really nice evening, all of you, and thanks for being here just online. Happy to see you all.
Thanks a lot.
Thank you.
Thank you.
Bye.
Bye.